international journals, been the member editorial board at over 8 peer-reviewed journals, and investigator over 15 national and multinational study projects. Welcome, sir, and thank you for joining us for this webinar. Today's agenda, we will be having the opening remarks from Hiremat sir, followed by the case presentation and the deliberation around the case amongst the moderators and the host director. We'll be following to the concluding remarks and we'll close with that. With that note, my humble request to all the audience who joined with us on live for this webinar to put your questions, if any, in the comment box which is provided at you, followed by the case presentation, which will be taken for the discussion, all the questions. So with that note, I would like to stop here and hand it over to Hiremat sir for further proceedings. Thank you, sir. Over to you.
Good evening, and thank you, Dr. Damadeep.
Yes.
Is the pronunciation correct, or?
Yes, sir. Yes, sir. Correct, sir.
Damadeep.
Yeah.
All right. So this course has been running for a while now. I think we have crossed 50 sessions already.
Yes, sir.
And we've had some exciting presentation. So today also we have one presentation, and if time permits, I could give another presentation. So I now request Dr. Who is presenting the case?
Yeah, Dr. Dharmendra Jain, sir. Dr.
Dharmendra Jain. Yes. Dr. Jain, you can go ahead and present your study.
Can you please unmute yourself, Dharmendra sir?
Thank you, sir, for giving us opportunity in this very prestigious series of events. So today, can I share my screen?
Sure, sir. Sure.
Can you see my slides, sir?
Yes, very well.
So, sir, this is a challenging case of diffuse heavily calcified LED successfully treated by IVS guided IVL balloon. And this was actually a ACS case which was having a disease in the LCX, which was also calcific and required a cutting balloon. And then we have gone for this. This was a clinical 50-year female, lateral wall MI 3 months back, post MI angina, echo was having RWMA, L6 and LA territory, EF was 45, and it was having double vessel disease. L6 proximal 100 ACS infarculated artery, and LED was proximal to mid diffuse calcific 80%, and plan was PCI to L6 plus minus LED. This was the angiogram. You can see the calcium, heavy calcium at the LED. You can see the LED without dye, and also the site at which 100% L6 was there. It required also efforts and cutting balloon. So first we fixed the LCX, and then I am showing the LED, which was having a critical stenosis proximal to mid diffuse disease. So then we put it, we used the NC balloon, then cutting balloon, and then finally this was the result for LCX. It was not big territory, and then we have done the IVS run for LED to just assess the calcium load. So IVS was passed, and this is the result. You can see very well that there was a calcium at from proximal to mid, and it was a 360-degree almost. Calcium was there at various places, and some calcific nodules were also there. As we all know that there are variables that predict the stent under expansion and malapposition when calcium is there. So these are the various factors, eccentricity. So if it is calcium ring 360-degree, which was there in this case, so it was a highly calcific arc. Then depth also, it was deep, and also protruding nodules are there at various places. And thickness wise, it's a thick, obviously, and length wise, it's also diffuse from proximal to mid. So all features were there with a heavy calcific disease. And the recommendations is that if NC scoring or cutting balloons are not working, then we can go for the laser or IVL therapy other than Rota or orbital atherectomy. So this is the shockwave therapy, IVL therapy, where we give the pulses, which are in this C2 plus, we have additional pulses options, and it's a single catheter which can treat the longer calcified regions, and there is a sterile sleeve for the connector cable. So it's quite hygienic and safe. So it's effective in concentric calcium, which is well established in this picture, that it breaks the calcium following the IVL, and the stent delivery is very smooth. So it offers the mechanical benefits of nodular and eccentric calcium. It breaks all of them. And this is the cartoon which is helpful to understand the people regarding this IVL, how it works. So it's expanding and collapsing vapor bubble, which create a short burst of sonic pressure waves. And these pressure waves travel through the vessel with an effective pressure of around 50 atmosphere. And there is a localized field effect within the vessel, which fractures the superficial and deep calcium both. So IVL was delivered in LED, mid to proximal, in various pulses, 20 or 10, depending on the calcium load. And finally, we got this result after IVL in LED. So this IVL therapy I found in various previous cases also, that after IVL, we found that it just looks like that after stenting, which we are expecting, that results come only with the IVL. So it's beautifully opened from proximal to mid, well prepared. And then we have done the post IVL IVS also, just to see what happened to the various calcific nodules. So you can see here that all calcium was fractured at various places by this IVL. So those rings were not there. Now it's a fractured calcium, and now it's the lesion is ready for the stenting. So we deployed 2 stents in LED, and post stent to LED. This is the spider view, and then we have done some post dilatations, and this is the final result. So we got very good end result after IVL and then stenting. And post stent IVUS run shows well opposed stent. And so calcium was handled beautifully, and you can see the very well opposed stent. So coronary artery calcification make PCI challenging sometime, and imaging and IVUS guidance helps in choosing right approach for management of PCI to calcified coronaries. And IVL can help to modify calcified coronaries to facilitate PCI in selected cases. So thank you very much for your kind attention.
Dr. Jain, can you also highlight the differences between calcium handled by Rota against calcium handled by IVL?
Definitely, sir. The Rota is putting the calcium into very microparticles, which goes down into the vessel, and there are chances of slow flow sometimes. So that is the most dangerous thing, which we do not want in any case. Sometimes slow flow is no flow also. And there are various other complications of Rota is there, including the bar stuck sometimes there is a perf also. So these things are there, should be kept in the mind when we are choosing Rota. Some of the orbital atherectomy, some of the benefits are there, that it is stuck bar problem is solved by the orbital atherectomy. It is having the both side cutting options, so stuck bar option is handled by orbital. And otherwise if in an experienced hand, these options are definitely being used since long. So rotational atherectomy is a good option, and can be used in selected cases.
The rotational handles only the superficial calcium,
Correct.
while IVL can
Right,
handle
IVL goes for deep also.
deep calcium. So I think whenever IVUS or OCT show that calcium is not just superficial but also deep,
Yeah,
I think IVL becomes the
choice.
option of choice. Yes,
Correct, sir. Very correct.
but very well done case. I think the final result looks brilliant and
Yes,
very
sir. I
good.
found, sir, with IVL, whatever little experience I have, those cases when I finished the IVL, angiogram was so good that after stenting, whatever we found the final lumen, that is there with IVL only. Thrombus, calcium, everything clean.
Yes, yes.
Dharmin, very excellent presentation.
Oh, Rastogi, sir, very good evening, sir.
Very
How are you?
excellent presentation, very well done. And it is absolutely correct that IVL, especially when you have a very high calcium load, it always supersedes Rota, as Dr. Hiramat was telling. In fact, it is very good. Long-term result of restenosis will come to know shortly when we were comparative studies. But I think it is IVL is always superior to Rota.
Correct, sir.
Any questions from the audience? And any questions from the faculty?
No questions, sir, so far from audience. So I request audience, if any questions, please put it in the comment box, which is there with you. And I urge Dr. Mukul, sir, if any something you want to add here into the discussion.
Good evening, all. I think case is very well presented and very well done. So, and Dr. Hiramat has already explained the doubt which even I also had between IVL and orbital atherectomy. So, if he can put some more light, like how to decide where to go for IVL and when to go for orbital atherectomy.
Cost issues are there, Dr. Mukul. That is another practical issue. IVL therapy is little costlier.
Definitely.
Yeah. Thank you.
Thank you.
Dr. Jain, do you think this case could have been done only with rotablation and something like a NC balloon or OPN-NC balloon? Which
Definitely, sir. We were doing it before IVL. We were doing the same case with the options which you are giving, sir. And I think use of IVL, it's very simple to use. It's if we can cross the IVL balloon, and then it's very simple. The procedure is very simple. We have to just give the pulses, and the result is there. So it's very simple. I think I found it very simple to finish such cases if the cost is not the issue.
Yeah, I mean, rotablation needs some kind of mental adjustment. There is a learning curve, and that's why Rota would probably need some expertise.
Correct, sir.
You have to do many cases before you say I am confident about Rota.
Yeah.
On that background, I think IVL is just like a conventional balloon. Take it in its good position.
Very simple.
Deliver the pulses. The indication has to be correct, and if you have chosen this, you work well. The Rota, however, has an advantage. IVL is a little bulky compared to rotablator, and
sometimes that is the challenge. Yeah, sometimes.
Yeah, I mean, even if there is a total occlusion, if the wire has gone, you can
use the Rota.
But the IVL balloon is not an easy balloon to get into location. So
Correct.
you probably need to pre-delay it and then for IVL.
Sometimes you need to modify it first, then you can put the IVL. That challenge is there. So you have to optimize, maybe required by NC balloon or something, cutting balloon, something may be required before IVL.
Quite true. But I mean, our experience with IVL has been quite good.
Sometimes Rota plus IVL is required, sir. Sometimes.
Yes.
That nodule is there and we could not cross by anything, then Rota is the option. We can put pass the wire down, then Rota is the best option.
Rotatripsy.
Rotatripsy.
Any other comments, Dr. Rastogi?
No, sir. I think you have explained everything very well. Only thing in tortuous vessel, I don't think we are always at trouble whether we have to do Rota or IVL if the vessel is tortuous in calcium. That's the only problem, because even passing a balloon of IVL is difficult, and doing a Rota and to then upgrade the burst becomes a problem. Tortuous vessel in calcification is always a problem. Otherwise, sir, you have already pointed out the main point, that sometimes you have to combine both, and IVL passing balloon is really difficult sometimes. As Dharmen was telling, if there is a more calcium load, you have first use a cutting balloon or you have to use a NC and then you can pass it.
Or combine Rota and IVL.
Only the problem is if you have a real tortuosity of the vessel, then sometimes with calcium it becomes difficult even to do a Rota. Even pro Rota is difficult to. That becomes a problem.
Correct.
But an excellent case, sir, and very well explained. I think it's wonderful.
Tortuosity is always a challenge, sir, to deliver any device, anything.
Tortuosity is real.
That is always a challenge. You have to choose all-star or something like steel wire to make it a straight, and you may need a more body wires to make it straight, and then only you can deliver something. We have done, sir, some cases of absorb when we have to prepare beforehand, well prepared in putting the absorb stand. That I have used hundreds of absorb, and we prepared it very well before. It was tortuous, it was calcific, it was thrombotic. We have used absorb, in all those cases, and we found that we have to prepare first. And then that point is very well taken, sir. Tortuosity is the very challenging case. Tortuosity is the only thing that challenges. So it's very tricky to handle it.
Very tricky. And the vessel sometimes even does not straighten to that extent. Even after putting a wire, you think it will straight, and then the smaller burr will go. That becomes always a problem.
So we have to put multiple stands, multiple small balloons like that. We have to choose the.
But I always agree, IVL, except for the cost, is much easier than Rota. That is always better.
Cost is too much, sir.
Cost is very high. That's the main issue.
It's too much. Its cost should be reduced, sir.
We hope so. We keep on using it. That's the only issue.
I hope the concerned people are listening to our discussion.
Right.
All right. So, Dhamadeep,
Yeah.
I have a case for presentation.
Please, sir.
Can I present it since
Please, sir.
there is a dropout?
We don't have
Yes,
any
sir.
question now.
We still have
I
about
request
half
you
hour to go.
Yeah. Yes. Yes. Please go. Thank you.
Yes.
Sir, just wanted to say, Dr. Hiremat sir, so thank you so much. And if the disturbance is not coming that much, then this is immense pleasure from the Emcure also that you are presenting the case, and the whole audience will be the witnessing the great case. We are very pretty sure about it. Thank you so much, sir, for presenting a case by your own self. We are very glad to have this and witnessing this case. Thank you so much, sir.
All right, so we go ahead with my case. We have about 20 minutes. So this gentleman was 58-year-old. He is hypertensive, but luckily no diabetes. And he has very aggressive angina in last month and little more. So about 6 to 8 weeks of angina. In fact, the story is he was booked for a CABG, and but every week before he went for CABG, he was getting into heart failure because of mitral regurgitation. So, I mean, patient had already spent about a month or so getting into hospital and going home, saying that you come next week and so on. And this is the angio. You can see the left main at distality is showing a critical narrowing. And beyond this, the LAD ostium shows mild narrowing, and circumflex ostium also is showing disease. Luckily, the right is a dominant vessel, but no critical narrowing. I mean, there is some narrowing in the mid portion, but maybe one could do an FFR, but we felt this was not contributing to the current problem. The patient was going into recurrent failure because of this vessel. The mitral regurg could be documented at grade 3 and 4 on echo. So what were the options? We thought the first stent would come somewhere here. The second stent would be to the diagonal. Third would be in LAD, and fourth will be left main to circumflex. Most of us like to stent left main to LAD, but this case, the circumflex was a dominant vessel. Right was also equally big vessel, but circ was also a dominant vessel. And we thought the diameter of the circumflex matched better with left main compared to diameter of LAD and left main. So we decided to put stents like this. And there were other few options also, like you put the stent. I mean, number one stent was no discussion. It was a type A focal block. The discussion was only about the distality of the left main. So there were some of us who felt the second stent could go like this. And then the third can come like this as a tap, and the fourth could come as another tap towards diagonal. Or somebody said, don't do anything to diagonal. My own feeling was this is the supply area, the papillary muscle, and mitral regurg was based on this. So I thought the dilatation to the origin of the diagonal, let's call it diagonal, but it looks more like ramus, was also very, very crucially important. And there were some other options like stent 2 would go to this diagonal vessel, stent 3 to LAD coming back to left main, and then stent 4 through that stent joining between the left main to the deployed diagonal stent. So we had our anesthesia team on high priority. In fact, the patient was intubated. You can see the tube here, and we got a long sheet, 55 centimeters, 7 French. We had a balloon pump, and the PA pressures were 65. As I mentioned, the mitral regurg was grade 3. And the family actually declined because of high surgical risk. The patient is on elective ventilators, Swangen's balloon, long sheet. Long sheet many times gives you a lot of support, and placement of stent or some kind of equipment through the guide becomes much easier since there is a support from long sheets. We use it very often when we want to save on contrast, and the vessels are very tortuous. There is a balloon pump and there is a temporary pacemaker. So all these were right at the beginning of the procedure. And I mean, as we discussed the middle branch, the one here, whether it's a branch of LAD or whether it's a branch of circumflex, or it's a true ramus coming out exactly between circumflex and LAD, whichever way, but we thought the stent between in this vessel should be more linked with the LAD. This was our field. So we had a EBU 7 French catheter. We use it very often for sicker cases because you can move it in and out very easily. And in this particular case, we used Fielder XT with a microcatheter. The whole idea was to move fast. So once the Fielder XT was in LAD, it's very easy to move it down. Over this, the microcatheter came in, and then you remove the microcatheter since this is a 300 centimeter length wire, extra length. And we did a Rota with 1.75 burr to left main distality and the LAD. So Rota was sort of, I mean, the fluoroscopy also showed calcium. And I guess we should have done, I was to sort of quantify the extent of calcium. Uh, 175 bar, and this is a post-Rota image. I think the arteries are feeling better, and you can see more dye flowing distally. I guess more blood was also flowing. So the idea was not to get the patient into any kind of LV failure on table. This same Fielder XT microcatheter combination was also used to get into circumflex, as you can see here. And so we did NC balloon 2.5. The left main distality, the balloon is looking towards the circumflex, as you can see here. The whole idea was to dilate the simple lesion first and stent it. So this is the lesion here. It was dilated with 2.5 NC and then a 3.5 into 18 onyx stent was placed at this site. So we have taken care of the simple lesion in the circumflex. Then we used OPN balloon 3.5 at the left main distality, one going towards circumflex, the other one, same balloon going towards the LAD. And thus we used a 2.5 NC balloon. Now this NC balloon we use very often as a pre-dilatation, primarily because we can avoid sort of a dissection because the balloon doesn't swell but exerts good quantum of pressure. So all the three vessels are well dilated. Now you might ask why we chose mini crush. As I told you, the patient was getting into repeated heart failure. In fact, almost 4 admissions, one every week in the preceding 4 weeks before the patient was kept for CPG. And we also chose mini crush as our technique because this allows you to put a side branch stent first, and patient would not go into failure because of mitral regurg. So the D1 is now getting this 2.5 into 15 onyx stent, gets in very easily. You are in position here. The back end is at the origin of the diagonal. And at the same time, we have placed this 3.5 into 22 stent in the LAD. So once we deploy this, we will probably like to deploy the LAD stent. So this is how the stent in diagonal is deployed. And the flows were good. Then we are doing a mini crush between LAD and left main circumflex stent. So this stent is LAD stent is placed at the mouth of the LAD. We take a LAO caudal view, make sure that we are in good position. And also, sometimes, if the stent protrudes back, it's difficult to take the next stent towards the circumflex. And that's why the stent is already placed towards circumflex. We already have a deployed stent in this position. We had no difficulty or no worries for that matter about dissecting the circumflex. This was a 4 into 38 stent towards circumflex from left main. So this is the technique we used. The mid circumflex stent was number 1. It was a straightforward stent. Second one was in diagonal mouth. Third one was at the LAD mouth, and then the stent towards circumflex. So left main LAD, left main circumflex stent was the last one to be opened up, and it's a 4.0, so a big diameter stent. Now, we made sure that the 4.0 stents gets into the deployed 3.5 stents here. This is very important because if at the end of it, you end up with a dissection related to this stent, I mean, it's an anxiety, it's a lot of sweat to put a stent in that location. You can see the undeployed stent from left main to circumflex getting into the deployed circumflex stent in a epicranial. So after this 4 stent were deployed, as I told you, first stent was a simple stent, type A lesion in the mid circumflex. Second was at the origin of the diagonal mini crush with stent in LAD, mini crush with a stent from left main to circumflex. Now, this is what I was telling you. The advantage of putting a 3.5 stent first was we could get this stent 4.0 to that stent, and thus any possibility of dissection at the display in such a complex case was avoided. Once stents were in place, we did this spot with a 4.5 balloon, and this stent is 4 into 38, but the pot balloon could be bigger, 4.5, and then we could wire the LAD and also wire the diagonal. Then we did the first case between LAD and diagonal with an appropriate sized NC balloon at high pressure. I would probably feel that the osseum of the diagonal has to be taken care very, very adequately. So NC balloon was used at very high pressure. Most of the time, the pressures are like 28, 30. And simultaneously, a balloon is also kept in the LAD. Then the kiss was between LAD balloon and the circumflex. And the flows are thus look quite good in this contrast picture. You see flows in the diagonal, good flows towards LAD, and good flows circumflex, which is quite a big vessel. So this is a final pot and final pictures, and you can see long stent lengths. This is 38 from left main to circumflex, and already 3.5 30 length stent deployed here. So it's a very long line. Stent at the mouth of diagonal and stent beginning from the mouth of LAD. Stories about year-old, and patient hasn't had any heart failure. He's walking around, and the family is very happy. All that I'm trying to say is for a given case, so many times you have to think differently. Like in this case, my own feeling is that diagonal vessel was responsible for the acute recurrent MI, responsible for failure. And that is why taking care, many times we put a stent in the side branch and we lose flow to the main branch, and we lose flow to the side branch. And then we sort of struggle. So whenever your case is critical, recurrent pain or recurrent symptoms because of heart failure and MR and heart failure in this case, I think doing the side branch first. And that is why we chose mini crush as our option. The PA pressures improved immediately. Mitral regurg regressed from 3 to 1, and it's over a year. The patient is doing very well. So this is how we started. This is pre. We did Rota to the LAD. Now you might think Rota was a wisdom because patient was going into heart failure prior to the procedure. But the LV function was good. Heart failure was because of mitral regurg. So we had no difficulty in considering Rota. Could we have used IVL? Maybe next time. But this is a story which is nearly a year old. And I think once we revascularized his all vessel, he's doing very well. Now, question was whether we should do the right. I mean, it's a simple lesion, but a dominant vessel, a very dominant vessel, and maybe we could have done an FFR, or now we could stress thallium to decide if right also needs the. But it's a type A lesion, and I'm sure there will be no difficulty. So this is the pre sort of trifurcation at the distality of the left vein. This is the lie of the 3 stands, the mini crush technique. And this is the contrast, taking good flow, all the vessels on the left side. See, the case is very important. So this is actually a kiss between LAD and D1, and this is a kiss between LAD and circumflex. A final part, like you finish all this and then again bring a pot balloon and make sure that you don't take the pot balloon too close to the bifurcation. So the final part, I always like to stay away from the bifurcation point. So that final part is slightly more backwards compared to the first part. So I think I will stop here. So exciting case, quite challenging, and probably the only time a reference was from surgeon to us. And we were very happy that we give family a very nice result on this case. So nearing a year, and this gentleman is walking around, and in fact is close to our house. So he always waves out to me when I'm gymming my morning workouts. Thank you indeed.
Very challenging case, sir. Left main trifurcation.
Yes.
Just like it's a threshold. Yeah. So
Absolutely.
it's a trifurcation. So it's been nicely done, sir. And you have shown that how in shortest time we can finish such a complex case so beautifully. It's wonderful, sir, to see such cases that inspires us to do more lab mains.
I think CTO is probably the only area where we still struggle a bit, but otherwise most of the lesions are now done by angioplasty, and we don't like to refer it to surgeon. Not that we do better job than them, but we can also do a good job, which could, especially somebody who has, say, 30, 35 years to go, somebody who is only 45 and has a multivessel disease.
People are coming at 45 also, sir.
To take
Such
them
complex
to
case.
85, you are going to need 2 procedures. So always think which one first. I mean, whether it should be angioplasty first and then a bypass, or bypass first and then an angioplasty. If you do a bypass first, you don't know how the disease will progress. So today, if a case is good for angioplasty, I think we should do an angioplasty by those 10, 15 years, and then ultimately go for surgery at some stage. So I think thinking line for a younger multivascular disease is probably different than somebody who is already 70 plus.
Very excellent done, sir. The most important was the decision, which stent to put, and then putting a left main to circumflex was really great. I think it's a wonderfully done case, very difficult. Trifurcation lesion, wonderful, and result is excellent. Excellent results. And I agree, sir, that diagonal was probably the most important because the MR regressed so fast from 3 to 1. The decision making is most important in this, sir. Most important is decision making, which comes only with the experience, probably. That's the most important. Wonderfully done, sir. Some of the best cases.
Thank you. So all my younger colleagues, I mean, this was a surgical case coming, not referred, but the family was sort of getting very anxious because patient was admitted as an acute heart failure 4 times preceding the surgical procedure. So we got to do a case, and 1 year has gone very well. Dr. Davade, is there anything else in store today, or we come to an end?
Yes, sir. We come to the end. Before that, I urge Dr. Mukul Bhatnagar, sir, to add something, if any, into the discussion.
Sure.
Mukul, sir, if you are there, please. I'm just checking for if any questions there. Sir, no question. We can proceed with your concluding remarks, and I will go then for the open things.
Yeah, I mean, I would like to sort of talk to my younger colleagues as well as peers that we have sort of passed through ups and downs of angioplasty. There was time when there were no stents, and for first, I think nearly 5 years, angioplasty was done just with balloons. So imagine proximal LAD, you do with balloon, and before the patient is shifted out of cath lab, sometimes he's in VF, sometimes he's in acute failure. So we've gone through all that, and in early days, we always had a surgical standby, but I think we do lots and lots of cases. I mean, we means everybody, without actually sort of discussing with the surgeon what we are going to do. So I think we should have a strong dedication, belief that we can do something important, and without sort of getting too aggressive, try and achieve results which are looking close to the surgical results. Thank you indeed. I always like this opportunity with of case discussion, and Emcure has been very, very kind in sort of supporting this symposium. It's a Pune firm, as many of you know, and the Lexim, which is a sort of great molecule for AMI. I think all over India, I think it's used, and I'm told that there are a lot of exports also. So we wish good luck and same kind of progress for Emcure.
Sir, so we are just on the age of concluding this webinar. I'm on my entire family grateful our course director Hirabat sir for directing us throughout this webinar, and not only directing but presenting an exciting case in front of us. So really a big and deepest gratitude for that from us. Then I'm thankful to both of our moderators, Dr. Puneet Rasmi sir and our another moderator, Bhatnagar sir, for again contributing to the discussion, the deliberations to be made. I'm having my deepest gratitude to our speaker, Professor Dr. Dharmendra Jain sir, for again putting interesting case scenario in front of us and presenting in a very nice manner. It was really interesting and insightful for all of us. With that note, I'm also thankful to all the delegates who are watching us, listening to us very patiently. With the hope of having 8 exciting and interesting session ahead in the next month, I wish a very good night to all and a good time ahead. Thank you very much for joining and having this, having your presence at this webinar. Thank you very much. Good night
This
and good time.
No Thrombosis is a monthly program, and we would soon announce dates for next month. I guess it will be post Diwali or pre Diwali. I'm not sure, but whatever, we'll let you know the dates. But do come, and if somebody is got some interesting cases, do let us know so that we'll try and schedule the case. Normally, we do 3 case presentations. So today we did 2, and I came as a stopgap, really. But if there are 3 good-sized cases, I think the experts may not do anything. Thank you indeed, and good night.
Thank you.
Thank you, sir.
Thank you so much, sir. Special thanks to Dr. Dharmendra Jain, sir, for presenting the fantastic case study, sir. And thank you to Dr. Puneet Rastogi, sir, and Mukul, sir, to present as a moderator. And a very special thanks and pleasant surprise also from Dr. Hiramat, sir, at a very good moment that he wanted to present the case. So this is a fantastic KT which I have attended. Thank you so much, sir, for your contribution. Thank you, sir.
Thank you. Bye, everybody. Good night.